All right, Rich. By my watch, it's 8 o'clock here in Eastern time here in Florida. 7 over there where you are. So you want to get started?
I'm ready. Do you really still wear a watch, man?
I do have a watch, but I also have a computer in front of me, which is actually where I saw the time change over to 8 o'clock.
Uh,
So it's more of a piece of jewelry maybe nowadays. But welcome everyone. I'm Dr. Guy Yatros. I'm on the left of the screen as you're looking at it, and there's my partner Rich Drake. We've been doing this for a long time, over 30 years between us, doing dental sleep, and this is all we do is do dental sleep in our practices and help other dentists who want to get involved in dental sleep. And I think we have some of the best systems and tried and true methods for implementing this in your practice. National Dentex, we've been working with them a long time as well. They're a full service lab, but they also do a lot of sleep appliances in addition to things like NTIs. I think I have a picture coming up on in a minute, and we've been working with them for years, and we appreciate their sponsorship of this webinar. This device, I say every time we have one of these that I wear this device most every night myself. I wear a device, and I do rotate them around. I wear different ones, but this is one of my favorites. And really, Rich, don't you think for $300 it's about the best value out there as far as a dental sleep
yeah,
device goes?
there's a lot of things that we like about this device, and some of our other webinar series we've talked about, choosing the right device and devices you can use, and this is one of the ones that's just high on our list. It's very compact. It's very strong. They do a lot of things well with this, and we appreciate their support.
And as you all know, the NDX has made the NTI famous. We still do these quite often for our patients with TMD, in particular muscle discomfort, and sometimes in between devices or in conjunction with. And it's just a wonderful tool to have in your toolbox for treatment of TMD and muscle discomfort associated with oftentimes with bruxism. And one of our new partners here, not new, but newer, we've been with NDX for many years. We've been working with KKGI, in particular instrumentarium. I did get a OP300, a Maxio OP300 in my office, and we use it for imaging all of our sleep patients these days, and it's really changed a lot about the way I look at the anatomy and so forth. So we appreciate their sponsorship as well. Rich, I think you always like to use our mission
Yeah,
statement.
we're the most trusted, innovative, and customer-focused provider of solutions in dental sleep medicine, period. It took us all day to come up with that, but that's what we do. We help dentists succeed in dental sleep medicine. It's just that simple. If you never made a single device or you make 100 devices a month, we can help you with our system. So we would appreciate you checking us out at some point. You can get free trials. We do all kinds of stuff from education to marketing, insurance. We're going to talk a lot about insurance and billing tonight, but we have an end-to-end patient practice management software that's the backbone of what we do. So check us out. I think you'll like what you see.
And this is exciting, and we promise we'll get to the billing right after this, and we will put the slide up at the end, and go ahead and keep typing in your questions. We will get to all of them. We're really excited about the North American Dental Sleep Medicine Symposium that we're doing next February 17th and 18th. It's at the Clearwater Hilton Resort, so it's on the beach. It's a really nice resort. Hopefully you'll come for more than that, but we have some of the country's leaders in dental sleep. You'll learn how to get your team on board, identifying pediatric patients, hybrid therapy, doing CPAP with your dental devices, choosing the best devices for your patients. One thing that always comes up, Rich, is people who maybe don't respond as well. We're going to have a segment on that, and basically much more that's really focused on practical how you do this in the country, everywhere from Dr. John Rimmers, who is by many given credit to coining the term obstructive sleep apnea, to Keith Thornton, who invented the TAP. There's a lot of well-known speakers, and we're excited to put that on. If you register, you can save $50 by putting in this code, SCPT, so September 50, by the 30th. It's only good through the 30th, which is Saturday, I think. It'll save you $50. And if you're a DS3 member, one of the many advantages to being DS3 members is you get discounts on lots of things from lab cases and to this course, so which saves several $100s for DS3 members as well. So we'll put that up at the end again. And we do courses all over the country, and we'll put this up at the end. We're getting towards the end of the year here to the fall. We've got a few left on the counter. I think there might be one more or so that's not on that particular flyer, but we do 1- and 2-day courses that can really get you going. So that's what we do, and if we can help you anywhere along the way, from anywhere from software to education, please let us know. And we're going to get started talking about billing. Is this what your team was today, Rich, when you walked in the office?
Every day they're excited to see me. So yeah, we laugh about this, but as dentists, we take ourselves off to the CE courses and we come back, and I think our staff views it a little bit differently than we do. Sometimes it's like, oh great, what do we have to sell now, or what do we have to do? Dental sleep is just different. You're dealing with insurance more than you do in dentistry, and it's just hard. I mean, your office manager's already busy, and I think that's how she feels, Guy, when you come back and you say, oh, yeah, I want to start making dental devices now, and you're going to have to file medical insurance for all these people. And they're like, oh, my gosh, how do we do that? So let's talk about it.
Yeah, well, so good luck with this, because it is medical insurance, not dental. And we have to.
That's the short answer there, guys.
That is the short answer, and it's a process, not an event. You have to change your mindset. We're going to talk about the differences in medical ethics versus dental ethics, and the billing in particular is different as well. So it really is totally different than anything that you might have done in your practice. And we talk about the 4 pillars of dental sleep, and I think a lot of our previous webinars were on these. And look how we have insurance billing as really one of the major ones, or what we really have to accomplish, because getting to the point where you're doing dental sleep and having a practice where you can sit back and relax and maybe not have some of the stress is an awful nice goal, and it's not that hard to obtain if you go down the right path. One thing I'll mention as we look at this slide, Rich, and this may be a newer slide than from last time that you and I did this, and we're dentists and dental team members on here tonight. And hopefully everything on the screen looks pretty normal here. Even the injection hopefully doesn't make us feel that uncomfortable. We're used to crowns and looking at x-rays, doing root canals. But how about this? If you have to do your own plumbing, or be your own attorney, build your own house, fly your own plane, do your own accounting. I mean, I think we're all pretty smart people, but man, we hire accountants who are trained, and they have experience, and they understand how to do these things. And so the quick really answer is that, if you think you know about medical billing because you've done dental billing, well, you might as well think you know how to fly a plane because you know how to drive a car. It is that different, and you really need to pay attention tonight and think about this. And really the real quick answer is, there are companies out there, including our own, that can help with this. Most medical offices don't even do their own medical billing anymore. They have companies that do it. And at least as you're getting started, consider using a third-party biller. And we're not really saying that to be self-serving as much as we really want people that we educate to learn how to do this. And once you get good at everything else, go ahead.
Guy, I think we say that, the more I think about it, is we really want dentists to be successful in doing this. And you saw the pillars there that Guy put up before. And we love doing this, and the patients love our treatment, and they feel better, and they sleep better, and they're happier. But the dentist can't get happy unless he's getting paid. And this is a challenge in your office, and that's why we say the quick answer is to use a third-party biller. If you just did it for 6 months or 12 months, you're not going to pay them that much money. Most people do it in the ballpark of 10% of what the insurance check is, not what you bill. And it kind of is a way, I think, Guy, to ease into this without getting so frustrated because you can't get paid, and then you give up on it before you even give it a chance to succeed.
Yes, correct. And we are happy. As a matter of fact, I think we're thrilled when one of the offices, our DS3 members that we're working with, gets to the point where they say, you know what, our volumes indicated, we're going to do our own billing. We're happy to help with that transition, and we're thrilled when they make that step for themselves. But you wouldn't hire a lab technician if you're doing 1 or 2 or 3 crowns a month to work in your practice. So until you get the volume up, it really makes sense. And really the difference is, I think this slide is hopefully when you think about this tomorrow and you're getting involved in dental sleep, maybe this will sink in that we are literally crossing over from dentistry to medicine when we do a dental device, a mandibular advancement device, on an apneic patient. We're doing a medical procedure for that patient, and it's a lot more serious. There's a lot of implications that has. And Rich, this looks familiar to you, I would assume, being a dentist for about the same number of years as I've been, for over a quarter century. So, you
Yeah,
know,
you almost. I think that's one of the hard parts, Guy. Is as a dentist, you kind of feel dirty if you have to write something off, and in medicine, it's really part of what we do as patients when we go in. You know, all you have to do sometimes is, hey, can you write some of that stuff off? And usually an office will say, yeah, sure we can.
right. Absolutely, and if you think about just your own experiences, the people that are listening out there this evening, I'm sure many of you have gone to the physician's office and experienced where the fee was a certain amount, and then they wrote some of it off. And if we look at the ethics and the ADA, the American Dental Association, they're not a governing body, but certainly we want to listen to their ethics and try to be ethical and listen to what their codes are. And they basically say a dentist who accepts an insurance payment as a payment in full, as a copayment, as a payment in full, without disclosing that to the insurance company, that the patient's portion won't be collected. That's overbilling. I think, you know, however you want to say that, if we get charged $1,000 for a crown and the insurance pays $700, if we don't collect the $300, we've been told that's overbilling and that's unethical. I think pretty much that's the longer you've been a dentist, the longer you are kind of ingrained in that thought. Anything more on that, Rich?
No, I think that's exactly how people feel, and I can't wait for you to put up the next slide, which comes from the AMA Code of Ethics, and it's just, you know, patients are made aware of their co-payments so that they're more conscious about the cost of healthcare. But as a doctor treating the patient, if you don't at least acknowledge financial hardships and at least in some way forgive or waive that co-payment, then you're not practicing medicine the right way. So, I mean, those are really different, Guy. I mean, they really are. I mean, you said as the longer you've been a dentist, the more you feel that way. And this is why I think a lot of dentists just feel dirty doing this in some way. They just don't feel like it's right. And the reality is that this is how the healthcare in medicine functions today. Certainly you want to have a reasonable fee, and you want to try to collect what you can from insurance, and you want to try to collect what you can from a patient. We're certainly not up here to tell you to charge somebody $1 million and only collect what insurance pays. We're not doing that at all, because we know that patients who pay something, they always feel like they have some skin in the game, right, Guy?
Absolutely.
Yeah, even if we saw an executive today, Guy, the wife of an executive, a big company, United Healthcare, they pay 100% in-network, 100% out-of-network.
Wow.
And we still made this woman pay $100, and she kept saying, but why? And I said, because I want you to have some skin in the game. You know, I'll give you your $100 back when the insurance pays the whole thing, but I want you to feel like something's going on here.
Right. And I think the take home there is, when it comes to this, these people need this. It can be life-altering. It can be life-saving. And if a patient really has an inability to pay and we can help them, the ethical thing to do is to collect what we can from the insurance and collect what we can from the patient and go ahead and extend and improve that patient's life. And I think if you keep what's right in the back of your mind, if you keep the patient's health and just what makes sense here, it all makes it makes that a lot easier for you to understand why the ethics literally are different. They're almost at 180 degrees, and it is because of the significance of what we were doing in the healthcare versus teeth, not to minimize teeth. And really what it comes down to is patients want to know how much it's going to cost them, and they want to know that their insurance is covering part of this, even if you reduce your fee and just say, I'm not dealing with insurance, patients want to know that, hey, I've got this insurance. I want to make sure it's being utilized as well. Uh, I think we'll talk in just a moment, Rich, about the different ways of doing this. And one model is I'm just going to wash my hands of insurance. I'm just going to come up with a cash fee, and my patients are going to pay me that, and maybe I'll file it if they get money back, or maybe I'll even file it. And that will work for seeing some of your patients. But what it will never do is allow you to work with the medical community referring to patients if you desire that. You get a lot of your patients from physicians. How do you think they would react if you said, oh, I charge $1,500 and we just don't deal with insurance, or $2,000 or $1,000? How do you think they would react?
They would say, well, good luck with that. I hope that's going well for you. Yeah. And I would never see a single referral. I would say from 98% of the physicians. So, I almost feel like sometimes, Guy, when I go into an office and I'm talking to a physician and I say, well, look, we deal with medical insurance. We file it for them. We get authorizations. They look at me like, finally, man, a dentist that gets it. They reach over and shake my hand, and I feel like one of these days one of them going, well, welcome to the dumb guys club. It's like, we've been doing this for 3 decades now. It's nice to see that a dentist has finally crossed over the line. But that's why we put that in there, how many MD referrals you get. We hear people all the time say, man, I can sell a $25,000 dental case all day long, but man, I can't sell a dental sleep device, without dealing with insurance. And I'm sure some of you on this webinar tonight have had those types of people coming back and some of those types of thoughts, and that's why you're sitting here listening to us tonight. But that's why we put that part in there about how many MD referrals you get. I mean, you really will do more dental devices if you deal with insurance, and you're going to get more referrals.
Absolutely, and don't say you have to do it, though. I think there's a part of some dentists who will just do this for their patients of record, and maybe it makes more sense for them to not get deeply vested in medical insurance billing. But look at what we have to say for the rest of the webinar and make a decision. I see one of the questions that came across here is, what do we charge? Well, I think the first thing you need to do is really figure out what you need in your practice for patients to pay you to make you happy to do this. If you need to be as profitable as you are on doing other procedures such as a crown, root canal, whatever you like to do in your practice, and figure out how much time you spend on that for you and your staff time, and how much the lab bill is, and then we can kind of reverse that formula. And what I think you'll find is a lot of practices will come somewhere in the $1,200 to $2,500, maybe $3,000 on the high end range that they need to do this. A lot of people out there say you can get $4,000 a case, and yeah, maybe hit or miss you can, but that's not what people really need. And I think we should really evaluate what we need to say, if I've got a sleep patient in my chair, how much money do I need to make as much money as I'm doing anything else? And I'm going to go through this fairly quickly because we don't want to take the whole night on this, but just take a procedure in your practice that you're doing, figure out how much you're charging for it. In this case scenario, I put a crown at $1,300, subtract out the lab fee. That's $1,000 in that scenario. And if you spend an hour of your time as a doctor, it's $1,000 an hour. If you spend chair time, if you're going by that, maybe it's 2 hours of chair time. And so it's $500 an hour. So just figure out how much time it takes you, and then reverse the formula. And if you're efficient and you use, especially the DS3 system, the chair time can be, when I say chair time, I mean assistants who are even doing this sometimes just on the phone talking to patients, 2.5 hours to an hour or under for doctor time. I mean, most of our offices we train are under 45 minutes for the doctor time, so we're giving you a little buffer there. And you reverse that formula and add a $350 lab fee, which is about the average. We even have ones that are less than that. And if you look at my formula here, it came out to less than $1,500. I think that's what most practices will find if they really put the pencil to it like that.
And that's a good point to remember, Guy. I want to drive that home, that at $1,500, you can make about what you're making doing your general dentistry type of stuff. But you got to have systems in place, and you got to be using them. So as we talk about insurance decisions, you got to deal with Medicare some way or another. We're going to talk about that. You have to be either in network or out of network with a medical insurer. There is no other option. I mean, and we'll talk about that. And then how do you bill these people? Do you accept assignment or do you not? So obviously it's medical. That's what we're talking about. We haven't seen a single dental insurance ever pay for any of this stuff. So, do they cover snoring, Guy?
No. Do they?
Okay. How about upper airway resistance?
No.
Okay. Well, every
Door
now and
number
then, maybe
three.
1 in 1,000, yeah, we get them to pay for it. But the diagnosis code, that does not come from us. That comes from the physician and a sleep study. But you're going to need that number. You need to write that number down, G47.33. And you can use the old code, but it's not as widely accepted. I think any day now they're going to switch over and just use the new code. But
Right.
remember, in general, patients have to have sleep studies, they have to have a diagnosis, and they have to have, sometimes there are even a minimum number of events and things like that. So as we look at this, I'm getting ready to sit down and do a consultation with a patient. My staff knows that we want a copy of the sleep test that the patient had. We want some type of sleep questionnaire. Are they sleepy? Are they tired? What's their chief complaint? How loud is their snoring? We do all this kind of stuff. And this is before we even consult with the patient. We want to verify their benefits. So the VOB stands for verification of benefits. DS3, we have a way to just click a button and make it happen. Basically, does the patient have insurance or not? Sometimes they let it expire. Do they have a deductible? What is their deductible in network? What is their deductible out of network? And how much of it have they met? And how much do they pay? They won't ever tell you what they allow, but they will give you a percentage of what they do. So this is a really good slide for you guys just getting started in this. This is what you have got to at least have a handle on. And this takes a little bit of time to do this. And that's why you got to have systems in place and to get the ball rolling in this.
Right. And again, you need some of this for insurance. What we do in our office is we take that information. If you're out of network, you won't, like Rich said, know the allowable amount. If you're in network, you will. That's part of the process. And we estimate the maximum amount of pocket for the patient. I call that the MOP in our practice. And we, the patients, if they want to know what's the most it's going to cost, and we can estimate that with this information here. This is what the instant eligibility check looks like through DS3. The click of a button, you can find all that information out on 4,500 billers, which is kind of cool. So you're always going to need those things that we just had for the consultation, because you need them for the consultation as well, but you also need them for the insurance. They want a copy of sleep test. They might need that questionnaire, which has clinical notes about why they can't wear CPAP or if they've tried it and so forth, and we make sure they have eligibility. Now what you need after the patient said yes to treatment and before we begin treatment, we need a letter of medical necessity. That's what the LOMN is, and a prescription from a physician, ideally the primary care physician. This is our way of letting them know that we're going to begin treatment. We typically send over the request to the primary care with a copy of the sleep test if they don't already have it, and a letter explaining why we want them to sign this piece of paper that says that our patient needs care. And again, it's two purposes. One is to make sure that the physician's working with us and we're not trying to sidestep them, but also most all insurance companies require this. And then the other thing you always have to have, is you have to have a way to submit this on the 1500 form. A lot of the dental softwares do not allow submission of electronic claims, in particular with the 1500 form, or even printing that out, and more it's electronic claims. So you have to have that. And again, like Rich said, these are good slides to pay attention to. Most of the time you also need a pre-authorization. A pre-authorization is different than the verification of benefits. Insurance companies require you to go through some hurdles sometimes, and sometimes it involves getting the primary care to initiate this, and so we have to do a pre-authorization that can take anywhere from a few days to a few weeks. If it's Medicare, we'll talk about this form, the advanced beneficiary notice, and a few things we occasionally need are the practice parameters, which are the just if they're denying it for some reason. But gosh, Rich, we used to always have to have that to get them to pay, and now most of the time, as long as we have these other things, we don't have to threaten the insurance companies to pay for these things in general.
I still threaten them, Guy.
You just like threatening people. That's what it is. No, I mean, we really don't. I mean, if sometimes you have to, but most of the time they have criteria about the severity of apnea and some issues. Typically, if it's severe apnea, they have to try CPAP first with a lot of the insurance carriers. If they're mild, you have to have some comorbidities, but we'll touch on with Medicare. But for the most part, they cover them. It's not like it's not covered. It's no longer that it's not covered like it used to be even 6, 7, 8 years ago. So if you're going to do
I
this,
would
what's that?
I would even say a year ago, Guy. I mean, we're
Yeah.
getting a lot more insurance companies to cover this now than we have, in the past. So that's all good stuff for you guys just getting started. And the first guys through the wall always get bloody. But Guy, you're in South Florida, so you've got to deal with Medicare patients. And I'm in San Antonio. We have a big retired military population that has Medicare and then TRICARE. That's a good combination to have. But remember with Medicare, it is a global fee. The E0486, that is the custom device that we use to do this, and the local coverage determinations for that vary by region. I think you have a slide for that coming up before a long Guy, but they only pay 80% of that allowable amount. And, the devices have to be approved by Medicare. And that list is growing every day. I mean, there are a few, but the TAP, the SUAD, the Herbst, I think Narval even has one now, a Medicare version and things like that. So there are those, but Medicare is a beast unto itself. And it doesn't particularly we don't deal with that the same way as we do with regular insurance.
Right. So Medicare, we'll talk about separately. Those are usually 65 and older patients, sometimes disabled patients. And the key thing here is the secondary insurance. Most people do have that. So a lot of Medicare patients are used to not paying anything for their treatment because their supplemental insurance pays that. And the moment you make a mandibular advancement device for a Medicare patient who has apnea, you're supposed to have declared something with Medicare. And this is totally different than the part, what is it, D, Rich, for the prescriptions that the ADA has been sending out, that you're supposed to be prescribing to get your patients to cover for the prescriptions. This is different. This is durable medical equipment, and it's a different part of Medicare, and you need to make a decision about what you're going to do with your Medicare patients here. And I think we're going to walk through that, and then we'll talk about what the fees are.
I love that maze you have there, Guy. Yeah, that's kind of what this is like. So I think I love this slide here because this really helps. I think will help you guys understand, how you have to deal with Medicare. So if you don't want to deal with it, you just want to be done with it, then you opt out. That is a 2-year contract. It's something you sign. It's a couple of pages long. You can't get back in for 2 years no matter how hard you try, okay? And it's something that you can get online, and basically what you're saying is you're not going to bill Medicare, and the patient that you treat can't bill Medicare either.
Right.
And then you have to have the patient sign this advanced beneficiary notice as part of what you do. But this is really designed to help protect the patient from going to see a doctor and thinking that Medicare is going to cover whatever the doctor is doing, when in reality they're not going to. If you think about how we would protect a Medicare patient, that's what that advanced beneficiary notice is for, and that's why we recommend that you use that, because it helps protect you as well as the patient.
Absolutely. And there's what the form looks like. And for the record, that's not what we recommend. The third option we're going to go into is what we recommend, which is to be a non-participating Medicare provider, but we want to make sure you understand all your options. The second option is you become a Medicare provider. And this is, we've mentioned multiple times here tonight, is durable medical equipment, DME. And if you do this, you basically have to accept the Medicare fee. And whatever they allow in your area, they'll pay the 80%, and the patient or the supplemental insurance will pay the other 20%. The checks will come right to you, and the patient, unless they don't have supplemental, will not be writing you any checks. So that would be great if the amounts were within what we wanted. And we really recommend that most people become this non-participating provider, which, Rich, you want to explain that?
Yeah, so again, that previous slide you said, that's a must for a cardiologist, the CMS 460. So you opt out, you opt in, and then there is this kind of hybrid in between. And the wording on these things is very confusing about how you do it. So you can say you are a Medicare provider for DME, even though you've not opted into Medicare. And we've got some slides here for how you do that. Leave that up just for a second, though, Guy,
Okay.
because go back to that just for a second, because I like that how you can see that. So the what's highlighted in red there is and this is what we recommend that dentists do as they get involved in this, and you have any significant Medicare population that you're going to treat at all. So you would fill out the 855S form. That allows you to be a DME supplier. Our dental devices are considered DME. DME stands for durable medical equipment. That's what our dental devices are. And the beauty of this system and how we've done this is that you can choose to accept assignment or not. So as we go through those next slides, I think, Guy, you get into that.
Right. Regardless of what you're going to do, Medicare, you have to get started on it because it can take anywhere from a couple of months to 6 months or more. And there's some obligations here, but it's not really scary. Don't let it scare you off. There's some protocols they ask you to follow through. They got to use their guidelines, use specific devices, but it's far well worthwhile being involved in. The beauty is if you become a non-participating provider, typically you don't check the accept assignment of benefits. In DS3, there's a place that you check that in the patient profile. If you don't check that, what that means is you're filing it for the patient, but the checks are going to go to the patient. Both the Medicare check and the supplemental insurance check is going to go to the patient, and you can bill the patient whatever your appropriate fee, whatever your normal fee is for this, and they pay you back. And if your fee's more than what Medicare pays, well, that's perfectly fine. But as a non-participating provider, if you have a patient who comes in who has that financial hardship, let's say they have a pretty severe apnea and they can't wear CPAP and they just tell you they can't afford any out-of-pocket because they have so many other medical expenses, you can check that accept assignment of benefits on a case-by-case basis. And for that particular one patient now, you'll be just like you're a full Medicare provider. The checks will come to you instead of going to the patient. So both the Medicare and the supplemental check will come to you, but now you can't balance bill the patient. So when we show you the slides for your regions, you'll be able to see what that means financially. But as a non-participating provider, you can kind of have the best of both worlds and kind of go in back and forth between the two. Miss anything on that, Rich?
No, that's excellent. That's a little bit confusing, we know, but remember, with Medicare, you opt out, you opt in, or you do the kind of the hybrid where you're non-participating and you do that. So a couple things to remember. E0486, which again is the code for our custom dental device, it is a global fee. So once you make that device for that patient, and you can't bill for the device until you deliver the device. I think that was a question earlier, and a very good question. And you're kind of married to this patient for 5 years. So if you're a Part B provider, you can bill for some office visits and things like that. But we're not going to get into that. So here's kind of the latest and greatest, and hopefully you've summarized that for us, Guy, in your next slide.
Yep.
As you look at this, yeah, so patients when you see a Medicare patient, the patient has to have a face-to-face with an MD to talk about the possibility that they have sleep disordered breathing. Then they have to have a sleep test. And then once they have a sleep test, if they're mild sleep apnea, then there are requirements for the minimum number of events that they have to have. And so you can sleep test somebody for 2 hours, and they have 10 events, so their RDI would be 5. That is a mild sleep apnea case and diagnosis, but you have to document that they have some of the other comorbidities, like daytime sleepiness, snoring, hypertension, things like that. So just remember, with Medicare, there are a few guidelines that you have to do. They have to see a doctor. You have to get the prescription from the MD. And it's also interesting, I see there, Guy, it's performed and billed by a dentist.
Right.
So Medicare guidelines say that physicians can't do this. It is within the scope of their practice, but they're not supposed to be doing it.
Right. And here's the jurisdictions. If you're lucky, jurisdiction A, and you may not think that until you see jurisdiction C, where Rich and I live, the allowable amount's $18.49, and you can see the 80% there, what that works out to be. So I'll leave that on for just a second. And if you lose any of these, feel free to contact our office. If you want it, if you didn't have a chance to write it down, we can be happy to answer that question for you. Tomorrow we'll give you our contact at the end, and as well as some information on the symposiums that are coming up and some discounts on those that we mentioned earlier at the beginning. So jurisdiction B, not quite as good, 1308, and I left that up there for a minute. And here's where Rich and I live, unfortunately, in the lowest jurisdiction, both Texas and Florida, in C, which is 1,066. So I'll leave that up for just a moment, and then we'll go to D, which is somewhere in the middle at 1321. And these are the 4 current regions. If you're watching a recorded version of this 2 years from now, this could all be different, obviously. It's always a moving target, but don't hesitate to get involved with Medicare. It really, to me, we see a lot of patients, obviously, here in Florida that have Medicare, and I actually like it better in many ways than the private pay insurance. They cover, we know how much they're going to pay. It's consistent. It just is a easier accounting to keep track of and everything. And here's where you go to get started. If you want help with this, the third-party billers, the companies that will help you with billing, most of them will also do your Medicare application for you for a fee. All right.
You know how long that takes, Guy? How long does it take you to write a check or give them your credit card number? So,
there you go.
So take them up on that. That's good advice. Okay, so we talked about Medicare in, out of network, and the hybrid. So let's talk about in and out of network now for medical companies. So
yeah, let's just make that clear, Rich, that Medicare is totally separate. So now we're closing the door on Medicare, and we're talking about all other medical insurance. Okay.
Right. So we're talking about everything else out there, from Blue Cross, United Healthcare, Cigna, Aetna, Humana, everything else. There are HMOs, there are PPOs. We'll talk a little bit about that. But, as a dentist, probably very few of you out there are in network with a medical insurance company. So I am with a few in San Antonio. And the reason I did that was there were a couple of oral surgeons who were in network with Aetna when I first got started. And and there's a lot of people here who have Aetna insurance, and they wouldn't give me a gap exception. I couldn't do it. So there's a reason behind why I did that, and there may be a reason why you want to do it. We're going to talk about some of that stuff, but it's a lengthy process to get involved with that. Not too bad, but you have to call provider relations, and then you have to get an application, and then you have to fill it out. Regionally, it's very specific. Some people will tell you they won't do this for dentists. 5 years ago, we heard that a lot. We don't hardly ever hear that anymore. But you got to remember, you're signing a contract with these people. You're saying, I am going to provide this service, and this is what I'm going to do. And then you have to negotiate a fee as part of this. And now you are bound to try to collect that from the patient. Now, can you still write that off? Yes, you can, and financial hardship and some other things. So, but again, think of yourself as a patient going to a doctor's office, and they're going to perform a heart catheter, and you would probably ask, what does it cost? What does my insurance cover? Am I in network or out of network? And one of the reasons patients ask that is because their deductibles are higher out of network than they are in. But as a dentist, you need to understand that you can do this. And there is a process, and again, a third-party biller is really the best and the easiest way to do this.
And I would mention the last thing on in-network, one of the key things are you do agree to the amount. So you do know how much they pay, so you can figure out to the penny what the patient's going to owe. The negative is that oftentimes the amount they want to pay you is less than you might get if you stay out of network. Unlike Medicare, if when it comes to other insurance, you are out of network by default. You don't have to opt out or fill out a form or anything like you do for Medicare. So you decide to become in, and we usually recommend that you try it where you are, and it is very regionally specific. Like Rich mentioned, he has a few of his challenges. I think you're in with 2 or 3 of them that you're in network. I'm not currently in with any in network, although we're considering going in network with one insurance company in particular, because there are other providers in the area, and the process for out-of-network billing is getting more difficult. If you happen to be out of not someone in your area who's in network, you can, on a case-by-case basis, apply for what's called gap coverage, and that just means that the patient had a lapse in their gap, a gap in their coverage, and so that there's not someone there to treat them, and you can become in network for that one particular case. Oftentimes the allowable amounts are greater for out of network, but also their deductibles are higher, and they pay less percentages. So you got to weigh all that together, along with the fact that you won't ever know to the penny what they're going to allow, because don't have a contract with them. If you are in network, there's really no billing system to this. You know how much they allow, you know how much the deductible is, you know what their co-pays. The only thing you may have to negotiate is financial hardships with your patients on occasion. When it comes to out of network, it becomes a little bit more complicated, because what are you going to do? I mean, Rich, this is what I did in my office for years. I just said, you know what? I had a fee-for-service dental practice, and initially we didn't even mess with medical insurance, but then we started saying, I'm going to mess with it, but I'm not going to check the accept assignment of benefits. I'm going to tell my patient, here's my fee. I'm going to submit it. If you get a penny back, well, too bad. And if you get it all back, well, great. And the patient is happy with that. They understand that they're fully out of the pocket, but there's patients who can't afford treatment, and I treated less people doing it that way. But that's a pretty, at least easy system to implement and to understand.
Yeah, I think that's the easiest for the dentist guy for sure. But like
Right.
you said, we're talking about a life and death disease here that can do that. So I think if you want to treat more patients, as a dentist getting involved in this, you have to be open-minded to some of these other things.
Yeah, and when you're looking at this, I think when I talk about a fixed or flexible system, what I mean by that is, look, if you do this math and you find out you need $2,000 to make you thrilled to do this, and you say, I'm going to collect that from everybody come, I just absolutely going to collect it. Well, the problem is you don't know what they're going to pay, so you're going to have to tell your patient you may be on the hook for $2,000, because I don't know what they're going to pay. And as far as the patient knows, they're going to remember that $2,000 figure. Now, your other choice is that you look at their financial hardships, and you're willing to take a gamble, and if the insurance company doesn't pay you as much as you thought, you basically take it on the chin as the office. And that's what I consider more of a flexible system, where sometimes you estimate the amount and maybe you're wrong, or the patient can't afford to pay you, and you have to accept less than what you thought you were going to get. And that's more of a flexible system. Well, if you're going to do a flexible system, you're going to have to increase your fees over what you need to make you happy to do this, because on occasion you're not going to get what you were hoping to get, because you're basically taking it, writing it off if you were wrong about that. So really picking a way that you're going to do this, and having a system in your office that everyone embraces, understands, and realizes it's for the betterment of the patient is important. I think the offices that have a challenge are offices that are kind of all over the board with this. Some patients, they expect them to pay them. Some people, they say, I'm going to charge you $2,000, but the patient hears that they're not going to pay anything until it doesn't cover it. And then there's consternation between the patient and what they heard and what you said, and there's some conflicts there. So picking a system and understanding it's key when it comes to the billing system.
Yeah, I would add to that, Guy, get the dentist out of the room. Dentists, they cause more problems, and I am that guy. Okay, that's how I know this, because I got a big heart and I want to help people, and I give more stuff away. If we let our office managers and our financial people go in there, and they make it more clear to the patient. So I, I think you did a great job of explaining that, Guy, and I just wanted to throw in the part about, dentist, shut your mouth, get out of the room, let somebody else deal with it.
Well, and I'll rephrase that, because some dentists, including myself, I think are decent at this. Have someone in charge of this, and someone who understands it, embraces it, and understands the whole situation. And you are correct. Oftentimes, the dentists themselves are not good at this, and so they should step aside if they're not and let someone do it. Or if they are good, then they could do it. But it's probably something better done by staff anyway, because we could be doing something more productive than having setting financial arrangements with our patients. So again, having a system and having someone accountable for it is key. And then you have to decide, how am I going to bill this? Am I going to bill just for the device, like the global fee as Medicare mandates? Or are we going to bill for the exam each time they come in for an office visit? Because we don't know, is it going to be 1, 2, 3, or 4 visits. Sometimes it's only 1 or 2. Sometimes it's 5 or 6. You're going to bill that patient each time. And if you are, then that patient needs to expect that, and you need to have that conversation ahead of time. I can tell you in my practice, we don't do that. We bill just for the E0486, and we do have the cone beam, as I mentioned earlier, and we bill for that. So we only have 2 fees. If you're going to bill for all the appointments, you darn well better make sure that that you have all the information you need to bill for the appointment, to dub information up so you're using the right codes.
So why do you say that, Guy? Why do I have to have the right information if I'm going to bill for a certain code? You mean I have to document certain things if I bill for certain codes?
Yeah, and so the easiest way to understand this is, if you do a crown on a patient, well, there's a crown on that patient. Your proof, but it really came down to it, is that patient has a crown on their tooth. If you do the E0486, we still need good, proper medical documentation. But the bottom line is, we have a lab script. The patient has the device. I even take pictures of them. I think it's kind of a good idea. So that's our proof that we did it. If you did an exam, or you had a consult with the patient to discuss how they were doing with their device and how their symptoms are, reviewing their sleep tests with them, and you want to bill for that, the only proof you have is in your medical documentation, and there are certain standards that medical documentation needs to adhere to. It comes down to reading these codes, and the codes that you're going to use, what their descriptions are. And as you know, Rich, I spent about 80 hours last year researching this. We have a module within our training that teaches how to bill for those codes, because it's a little bit more it's a lot more complicated, to be quite honest.
Yeah, so the take-home message there is just document. We've heard that our entire lives as a dentist: document, document, document. The beautiful thing about some of the medical plans and insurance, though, is you can get paid for using your brain.
Right.
And talking to people and just documenting how they're feeling and what they're doing and things like that. So, are we getting close to the end, Guy?
Getting it wrapped up here. I mean, so essentially, Medicare status should be number 1 on your list if you're going to get involved in dental sleep. Make a decision: opt in, opt out, or become a non-participating, that hybrid. I like the words you used for that, Rich. I'll be using that the next time I teach this. Status is what we recommend. You're going to be out of network until you decide to become in, so you're going to need to use a billing system that you're comfortable with. And then also which codes you're going to use with that billing system. And you want to keep it simple. Do the E0486. If you have a cone beam and you're doing that, then that's real simple to charge for too. So, and some medical insurances do reimburse patients quite well for those as well. And then really the last thing is, are you going to do this yourself, or are you going to get help? Again, I know it may come across as self-serving, but we honestly have the sincere desire that dentists learn how to do this and do it well. And we love it when their offices are doing it for themselves. But until you get all your other systems in place, leave this to someone to help. It really boils down to this, doesn't it, Rich? The less expensive out of a pocket that comes, the higher the acceptance rates are. That's really what the less the patient has to pay, the more we're going to do. And we need to know our laws when it comes to that. And we got to have a system for it that everyone, at least who talks to the patients about money, understands. And I think that's where we consult with hundreds and hundreds of offices, and sometimes the disconnect is, one team member understands it, but then when the patient asks another team member, they try to explain it and they don't understand it, instead of saying, you know what, let me get John or Jane over here who deals with that. Everybody doesn't have to be fully vested in the billing process, but you need to have systems in place to where they can direct patients to the right people who have the correct and consistent answers.
I think that's a real good tip there, Guy. Just one person in your office that understands it, and let them do the talking to the patient. You do not want to confuse the patients. The time this comes back to bite you in the rear end is when, well, Cindy told me it would only be this, and they told me it'd only be that. So get them to sign something. Do the best you can to estimate what they are. Get them to sign a commitment that they're going to pay X amount, and you're going to do the insurance and that kind of stuff. But I mean, Guy, the lesson. I think this is true for a crown or a dental sleep device, or just about anything, isn't it?
Sell more cars if they're less money. I think it's the more a patient has to pay, the less cases you're going to do. And that sounds kind of like we're trying to build our practice and make money, and maybe that's part of it, but really we could rephrase that and say the less the patient has to pay, the more lives we're going to save or extend or improve. We could rephrase it that way, and I think this is really true. We are helping people. Rich and I could spend a whole hour just talking about the people and the cases we know where it didn't turn out so well, and it's a whole lot worse than an abscessed tooth or a broken crown when it goes poorly. So the more we can get people helped, the more people we're going to help, and it's important. It's life altering. And I know this in my practice. I tracked this back when I had my fee-for-service practice, and about a third of the people or less would say yes to treatment when they had to just look. It's going to be X amount, and that's that. We started accepting assignment of benefits at one point, but we were kind of in that non-flexible. Look, you're going to have to pay me if they don't pay me for some reason, so you're on the hook for the full amount, but most likely it's going to be this amount. And it went up some, but because those patients knew there was a chance they would have to pay significantly more than what we were estimating, it didn't go up that much. But once we started more of a flexible system, and you know what, I'm kind of like you, Rich. If the patient really needs this, I want them to pay something. I try to get them to pay more than the $100 you did, $300, $400, maybe $500, so they have some, as you said, skin in the game. But if I can keep it to that, and I can work with their insurance and just try to help them based on their insurance and their ability to pay, we get near 3 out of 4 patients that we see for consults to say yes to treatment. So it's not just about making money, because some cases we lose money on. Some cases we do quite well, but we're helping people. It's enjoyable. We're making a living as we do it, and there's really not much more exciting than to literally get paid for saving and improving patients' lives.
Yeah, we use that term meaningful work a lot, don't we, Guy? I mean,
Yes.
as a dentist, we certainly don't want to belittle what we do. We fix teeth, we get people out of pain, we make smiles pretty, we do a lot of those things, and there's absolutely nothing wrong with that. But you're really stepping up the game here when you get involved in this and do it. So we think that the few hurdles that you have to jump through and some of the things that you have to do, we think it's very much worth it. I mean, look at the return on investment here. If you're just, average per device is $2,700 in this instance, and you're going to take impressions and even pay a third-party biller for something and have to pay a lab fee. I mean, if you did one device every other month, you still make money at this. If you do, one a month, you can buy a decent car for that these days. At 2 a month, you see the numbers there. It's just,
Yeah.
And we think one device a week is very reasonable for any dentist in the United States who employs a hygienist who sees 7 or 8 patients a day. And you start a system where you're screening your patients and you have a system down for what do you do after you screen them. Well, we want to facilitate that sleep test. We want to verify their benefits. We want to authorize it. We want to get their out-of-pocket as low as we can. They sign a financial arrangement. We get the prescription, the letter of medical necessity, copy of their sleep study. So there are just several moving parts here. But, you know, for what you pay us at DS3, you only have to make a couple of devices a year. And we are just an unbelievable resource of information as far as how to do this.
And I don't think we're playing any games here. You know, even if you lower that amount, one device a week with 4 weeks off, it's near six figures. Even after you pay us our fees, if you choose to be more efficient about it and join us. So that's not why you should do it. I think you should do it because it's the right thing to do. It's meaningful work. Our patients need our help, and it's the obstructive sleep apnea is the most undiagnosed, untreated, serious medical disorder in our country. And we as dentists have an opportunity and obligation to help. Yes, we can make extra money on top of that, which is even icing on the cake. So hopefully that's helped you with billing. A few announcements. We're going to stay on here and answer these questions as long as it takes. If you want to try our services, just type in free trial. And, you know, we're not high pressure people. We'll show you what we have to offer you. You've got a ton of information you can gain just from a few weeks of trial. There's videos, there's education. Our member support expert team can help answer your questions and kind of get you on the path to doing this. So just type in free trial if you want to do that. And don't forget, because some of you who showed up late, we're having, I think it's going to be one of the best meetings of all time, of ever, this next winter, February 17th and 18th, at the Clearwater Hilton. It's right on the beach. It's a resort. It's really a nice facility. I've personally visited it myself. I hope that's not the only reason you're going to come. I hope you're coming because we have some of the country's experts talking about dental sleep, and they're going to all talk about real practical uses, things that you can do right in your office that are not real high-level things that are you know, meta-analysis and things. It's going to be go back to my office and utilize this information Monday. Everything from getting your team on board in dental sleep medicine to identifying your pediatric patients, hybrid therapy, how you can combine CPAP and dental devices, which devices to use best. So Rich and I love talking about that. We'll be doing that one together. And, you know, how do we deal with patients who maybe don't respond quite as well? And again, many, many more, some of the country's experts from myself, Rich will be there, Aaron Elliott, speaking to your teams. We've got Keith Thornton, who invented the tap, and even John Remmers, who is a physician who is one of the first ones to ever discover obstructive sleep apnea. So it should be a great time.
I remember talking to John one time, guy, and he said, somebody said AutoPAP, and he said, oh, yeah, I invented that. Yeah. So, yeah, we're going to have some great people there. Hey, I've got an idea, guy. This is around Valentine's Day. You're going to be in Florida in February on the beach. Why don't you bring your significant other?
Yeah, we have a room block, too, that's a discounted rate that are going fairly quickly, so make sure you sign up for that. And we have a discount. It's $50 off just until Saturday, till September 30th. If you put the discount code in, September 50, SEPT 50, you'll get $50 off. And if you're already a DS3 member, you save several $100s by being a DS3 member. That's we have many benefits. A lot of our members actually save more money by lab discounts and discounts like this than what they pay us each year, because we're consistently helping them with making their practices better. So hope to see a lot of people there. We're very excited about it. We do have some 1- and 2-day courses that we'll be adding a bunch more on our calendars for next year. And here's some of the upcoming ones. I was just in Rochester last week. We've got a few more. I think there's 1 or 2 that aren't even listed on there. So lastly, if you haven't subscribed and you want to just have some free information, we have Dental Sleep Insider. It's Dental Sleep Medicine Insider is the name of the magazine. You go to dentalsleepinsider.com. It's free. Sign up once a month. You'll get it in your inbox. Great articles. Rich always writes a great article. I'm a little not as good at my command of the English language is not as great as Rich's are, so I'll do a video usually on these, and it's actually videos. I just filmed one yesterday, Rich. It's going to be in one coming up on how to repair a device. You know, they come in, they're broken. You don't want to send it back to the lab. The patient's in the chair. How do you do it? And you know, just real practical things like that, how to keep the tap screwed.
There's an unbelievable amount of good information in there. I mean,
Yeah.
and it's digital. You just pull it up, you turn the pages. If you want to watch a video, you click on it. It's really cool stuff, and that's just free out there waiting for you.
There's how you get a hold
Take
of us too. So, I mean, we're coming up on 9, but we're going to keep answering these questions here. I know, Rich, you've been typing a lot of them in as we've been going. I'm going to open that up and see where we are with answering most of those. Again, type in that
You did.
SCP.
I think it looks. Yeah, I think it looks pretty good. So
I'll back this
yeah,
up and make sure that everybody still has. I think someone requested that I go through those again. So there's your free trial information, and then again it's SEPT 30 for that code. And let's see, we'll go to that one, and we'll
let
end
me
up.
add just one more thing, Guy, with how you started this thing. That this is a process. So you have started. If you have not made a dental device yet, and you want to get started in this, then you have a real good idea about how to do it now and how to get paid. But it takes practice, and it takes a commitment. You've got to put some effort into this. You've got to have somebody in your office take command of this and do this. But I love what you said earlier, Guy, about it being a process. It takes a little bit of time to do this. That's why we recommend the third-party billers to help you get doing this and get you paid early on so that you can get over the hump and be successful at this.
Yeah, that's perfect, Rich. Well, I think, wow, we're on top of it. About ready to get off. One last question. We'll just answer it verbally. If a patient doesn't have a current sleep study, can you receive patients, insurance companies, will they pay for this? No, they have to have a sleep study, and usually it's within the last 2 years, sometimes longer than that, sometimes 1 year. You have to have we had up that said you have to have sleep studies, one of them with obstructive sleep apnea. So how old that study can be depends on the insurance company. 1 year or under, you're usually golden. More than 3 years, you might need to worry.
That's good. I see another one here too, Guy, about somebody from Wisconsin. He says we've been screening our patients, and once we get them to the physician and they do a sleep test, and the dentist is out. So that's one of the things that I'm going to be talking about at our sleep symposium is how we get over that. But let me just give you the nitty gritty on that might help is you've got to break into that system somehow. You have these sleep docs that all they ever learned was CPAP. They had one guy that had a dental device one time, and it wasn't even a work. So get in front of that physician, and you have got to tell him that these dental devices work. Just throw me a bone. Throw me your CPAP failures. I'm going to work with medical insurance. I'm going to do everything I can to help these patients get treated. So if you can get in there and kind of break the ice on that, and another option is if you have other sleep docs in town, go find them and tell them you would love to refer your patients to them, but you want some of them back. So some of you guys are in a town where you only have one sleep doc, and they make the rules with this stuff, and I feel for you. But that's one way to try to get in there and try to effect a change in how this is being done.
Right, and there's companies that we work with. You can contact us. You can order sleep tests through DS3 with various sleep companies. So it's going to become a lot easier. One of the slides we often use is this railroad track through the forest that when we started this, there was nothing but trees and woods, and because you had to go to a sleep lab to get tested. I mean, that was the only way of doing it. Now there's home sleep tests that you can have your patients, even at the click of a button, you can get these sleep tests now. So that hurdle's gone down. We've tore down a lot of the hurdles that we needed. Insurance companies, when we started this, they hardly ever paid for this. I mean, this webinar would have taken 2 minutes because we'd have said, well, we'd have stopped at the good luck with that billing medical insurance companies because they just don't pay, and now they do. And the parameters, as we talked about, some of our past webinars have changed where dentistry is dental sleep devices rather are recommended as a first line of therapy for patients with apnea. No longer is surgery up there. Dental devices are up there. So a lot of things have changed, and it's the right time. And you just have to have systems. That's why we exist, is the systems that we have, are the systems we have, I should say, because there's a lot of questions like the ones coming through that have to be answered, in their systems that need to be in place, and that's what we do.
Yeah, there's one more there too from Dr. Palambaro too about, he says, hey, I'm open to getting in network with a medical provider, but they want me to take their dental fee schedule as well. So we're hearing that more and more across the country. And, right now we're trying to figure that one out. I think
And
that
we do have a solution for that. I'll leave that hanging out there. We have a solution,
okay,
one of the companies we work with through DS3, that you can immediately become in network with multiple providers. And it's basically done through a third party, and there is a solution for that, absolutely. The other solution is that you can argue that point. I mean, everything's negotiable in life. You can argue it yourself, but if you want to immediately be in network, talk to us. We have one of our partners we work with who can help you become immediately in network and be up and running very quickly. So
and
again,
that's what we do. We don't want this to be too self-serving. We want to teach dentists how to do this and be successful, but that's what Dental Sleep Solutions does. The software is the backbone for that. We provide systems and unbelievable customer service support team. We have all kinds of, from Dental Sleep Insider magazines to built-in continuing education to all kinds of stuff just for the 1,000 questions that you're going to have about how you do this. That's what we're there for. All right, Guy, I think we about got it covered, man. Thank you so much for
buddy.
putting that PowerPoint together.
Sounds great. Well, we look forward to meeting some of you all on purpose, and hopefully you'll come up to us one day and say, we helped change your practice for the better. That's why we're passionate about this. That we hear great success stories from hundreds of our dentists, and it's very rewarding to know that we're helping improve your practices as well as your patients' health and life. So have a good night, everybody, and thanks a lot for your attention.
Have a good night, guys.